Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the brachial plexus injuries. The brachial plexus is a somatic nerve plexus. It is formed by the ventral rami of C5, C6, C7, C8 and T1 spinal nerves. It is formed in the posterior triangle of the neck, extending behind the clavicle above the first rib through the axillary inlet to the axilla. The brachial plexus innervates almost all the muscles of the upper extremity. The brachial plexus is vulnerable to injury. I will discuss the applied anatomy of the brachial plexus injury. Okay. I will discuss about the injuries of the upper trunk, lower trunk, also I'll emphasize on the Horner's syndrome. Horner's syndrome associated with brachial plexus injury. I will also include the injuries to the branches of the brachial plexus. The upper trunk injury is also called Erb-Duchenne Palsy. Palsy or paralysis. Lower trunk injury is also called Klumpke's palsy or paralysis. We have injuries to the branches of the brachial plexus. It includes the axillary nerve injury, injuries to the radial nerve, injuries to the ulnar nerve, median nerve. Okay, so any part of the brachial plexus may be injured depending on type of trauma or accident or violence. So let's start from upper trunk injury or Erb-Duchenne paralysis. What happened? We know that brachial plexus is formed by C5, C6, C7, C8 and T1 ventral rami of the spinal nerve. So C5, C6 together form upper trunk, C7 forms middle trunk, C8, T1 forms the lower trunk. So this is upper trunk. From the upper trunk we have divisions, anterior division and the posterior division. We have the anterior division and the posterior division. We have the anterior division and posterior division. Okay, so from upper trunk we get the anterior division, posterior division. This division, anterior division of the upper trunk and the middle trunk will unite to form the lateral cord. So these are the divisions, these are the roots, these are the trunks. We have upper trunk, this is upper trunk, this is the middle trunk, this is the lower trunk. All posterior division will unite to form the posterior cord. The anterior division of the lower trunk will form the medial cord. This is posterior cord. Posterior cord is formed by the union of posterior division of the upper trunk, posterior division of the middle trunk, posterior division of the lower trunk. The anterior division of the lower trunk forms the medial cord. This is the medial cord. Okay. We'll go to the injury to the upper trunk. This is the upper trunk and we call it Erb-Duchenne paralysis. Upper trunk is contributed by the C5, C6. And due to upper trunk injury, we will have Erb-Duchenne paralysis. Okay. So upper trunk injury will lead to Erb-Duchenne paralysis. We have C5, C6 unite to form upper trunk and muscle will be paralyzed or the deltoid muscle. We have the biceps brachii muscle, brachialis muscle. We have damage to the supraspinatus, and infraspinatus muscle. We have damage to the nerve to the subclavius, the subclavius muscle, nerve to the subclavius, supplying the subclavius muscle. Okay. We may have also injury to the brachioradialis. So upper trunk injury will lead to lack of function of all these muscles. So what will happen? Person will unable to laterally rotate the upper extremity. Person will unable to supinate because biceps brachii is a supinator at the superior radioulnar joint. Deltoid muscle, especially the posterior fibers and also the lateral fiber, are associated with the lateral rotation. Flexion will be also lost because biceps brachii also flexes the elbow joint. Brachialis is also a flexor of the elbow joint, and also functions of supraspinatus, infraspinatus will be lost. This is a small muscle subclavius. Brachioradialis function will also be disturbed in case of Erb-Duchenne paralysis, and people upper limb will hang by the side and it will face back, the palm will face back, okay, and flexion and supination is not possible. We call it Waiter's tip sign. We'll get Waiter's tip sign. Okay, this is the lesion due to the upper trunk of the brachial plexus. Upper trunk is formed by the ventral rami of C5, C6. Then we'll go to the lower trunk of the brachial plexus. Okay, so how about lower trunk? Lower trunk injury, it is called Klumpke's paralysis. Klumpke's paralysis or palsy. Lower trunk, how it is formed? lower trunk is formed by the C8, T1 unite to form the lower trunk of the brachial plexus, and C8, T1 innervates the intrinsic muscles of the hand. So what happens? If the lower trunk is damaged, then intrinsic muscle will be atrophied, non-functional, and the person will develop claw hand. Okay. So we have upper trunk injury that causes Erb-Duchenne paralysis, lower trunk injury called Klumpke's paralysis. Erb-Duchenne paralysis is more common than that of the Klumpke's paralysis. What type of injury happen in upper trunk palsy or Erb-Duchenne palsy? Erb-Duchenne palsy. Okay, that is upper trunk palsy. Okay, this may be due to birth trauma, due to excessive lateral traction of the head. So excessive lateral traction of the head, okay, that may lead to Erb-Duchenne palsy or upper trunk palsy, or any other trauma that damages the upper trunk of the brachial plexus. Upper trunk is formed by C5, C6. Muscles paralyzed are the deltoid, biceps brachii, brachialis, and also the small muscles of the shoulder. So you got the Erb-Duchenne paralysis, Klumpke's paralysis, or lower trunk paralysis, or Klumpke's paralysis. Klumpke's palsy. Okay. This may be also due to birth trauma, especially pulling by the hand. Okay, that may lead to due to damage to the lower trunk of the brachial plexus, or a person is falling from a tree top, and luckily he was able to hold a tree and he was able to break the fall. Due to sudden jerk, there will be excessive angulation between the upper arm and the chest that will lead to Klumpke's paralysis. So birth trauma may lead to Erb-Duchenne paralysis, or it may lead to Klumpke's paralysis depending on the presentation. Okay, so especially in difficult breech presentation of the baby, pulling by hand of the baby may lead to Klumpke's paralysis. Okay, so we got the brachial plexus injury, Erb-Duchenne paralysis, and Klumpke's paralysis. These paralysis may be associated with Horner syndrome. Especially in case of lower trunk palsy. Why this happen? Because there will be disruption of the sympathetic fiber to the cervical sympathetic chain of ganglion. We know that the sympathetic system is a thoracolumbar outflow from T1 to L2. From T1, T2, T3, our head and neck is getting the sympathetic flow from the lateral gray horn. From lateral gray horn, the sympathetic fiber are coming out to the, then it will be in the spinal nerve. Then we'll have the connection of the sympathetic ganglion through the white rami communicants, and the nerve fiber will come out from the ganglion through the gray rami communicants. Some fiber go up, some fiber go down. So the sympathetic chain of ganglion are related to the spinal nerve. Spinal nerve also contribute in the formation of the brachial plexus. So if there is any injury to the brachial plexus, especially the lower trunk, the sympathetic nerve flow to the cervical chain of sympathetic ganglion will be disrupted. That will lead to Horner syndrome. And in Horner syndrome, we'll get ptosis, partial ptosis. Cervical sympathetic ganglion goes along with the blood vessel to supply the dilator pupilla. The dilator pupilla cannot dilate the pupil, then the sphincter pupilla will take upper hand, so there will be meiosis or pupil constriction, because dilator pupilla cannot work, so sphincter pupilla will work and it causes pupil constriction. Partial ptosis. Why there is partial ptosis? Partial ptosis due to non-function or lack of nerve supply to the superior tarsal muscle. Superior tarsal muscle, okay, becomes inactive because of lack of sympathetic innervation to the superior tarsal muscle. This is a smooth muscle. It is innervated by the sympathetic fibers. So the superior tarsal muscle becomes inactive. So there will be partial ptosis, also called pseudotosis. Okay, this muscle is also called the molar muscle. Okay, molar muscle palsy or paralysis. Same, superior tarsal muscle, same as molar muscle. Okay, we got the ptosis and we got the meiosis. So we have ptosis, that is drooping of the upper eyelid due to non-function or lack of function of the superior tarsal muscle or molar muscle. We have meiosis because of non-function of the dilator pupilla and unbalanced action by the sphincter pupilla. We have also anhydrosis because our head and neck is getting sympathetic innervation to the sweat gland. So sweat gland will not be active. So there will be dryness here, flushing of the face, warmth filling the air. This is due to lack of sympathetic innervation. So there will be lack of sweating. We call it anhydrosis. So this may happen due to injury to the thoracic spinal nerve and disruption of the sympathetic nerve fiber through the sympathetic chain of ganglion. Plus, we may get Horner syndrome due to Pancoast tumor or apical lung tumor, Pancoast tumor or apical lung tumor. Okay. We may have Horner syndrome due to involvement of the ganglions by means of the breast cancer, spread of the breast cancer or any other cancer that involve the stellate ganglion. Okay. Stellate ganglion is also called cervicothoracic ganglion. It is a ganglion formed by the union of the inferior cervical sympathetic ganglion and first thoracic sympathetic ganglion. The stellate ganglion is located, this is same as cervicothoracic ganglion, this is located in front of the transverse process of C7. So if these are involved in any type of cancer like breast cancer or apical lung cancer, we may get Horner syndrome. Okay, so Horner syndrome may be due to traumatic condition, may be associated with brachial plexus injury, may be due to other reasons like spread of cancer. Okay, we got that. Now we'll go to the individual nerves. We have multiple nerves at the branches of the brachial plexus. Axillary nerve may be damaged. Axillary nerve root value is C5, C6. Okay, C5, C6. It innervates the deltoid muscle and the teres minor muscle. It also innervates the upper part of the lateral aspect of the arm skin. So in Erb-Duchenne paralysis, in addition to the Wetter's tip sign, we have also loss of sensation from the lateral aspect of the upper part of the arm, because axillary nerve provide the lateral superior cutaneous branch of the arm. So this nerve may be damaged due to fracture of the surgical neck of the humerus, surgical neck of the humerus. Axillary nerve may be non-functional or undergo lesion in case of shoulder dislocation. Okay. So what will happen? Axillary nerve, if it is involved, if it is damaged, then deltoid will not get innervation. So eventually the muscle will be atrophied and the accruement process will be very prominent. And person cannot abduct from 15 degree to 90 degree. Okay. We got the axillary nerve lesion. We may have lesion in the musculocutaneous nerve, although very rare, musculocutaneous nerve lesion. This is rare, not very common, but if it may be damaged due to trauma or injury, maybe gunshot injury or any other road traffic accident. Okay, so it may happen. What will happen? The biceps brachii, brachialis muscle, okay, coracobrachialis muscle will be paralyzed, and there will be lack of sensation from the lateral aspect of the forearm, because the cutaneous nerve, the lateral cutaneous nerve of the forearm is a branch of is a continuation of the musculocutaneous nerve. It is rarely involved, but it may be involved. We may have lesion to the ulnar nerve. Okay, so ulnar nerve lesion will be like that of Klumpke's paralysis. Okay, what will happen? We have ulnar nerve coming from the medial cord. What is the root value? C8T1. So like that of the Klumpke's paralysis, here we also get claw hand. So claw hand is a feature of lower trunk lesion and also ulnar nerve lesion. So person has claw hand due to ulnar nerve palsy, or maybe due to lower trunk palsy or Klumpke's palsy. Okay. Ulnar nerve may be damaged in multiple places. Ulnar nerve may be damaged, may be damaged anywhere. Okay, may be damaged. What are the sites? It may be damaged at the medial epicondyle area. Any injury to the medial epicondyle, ulnar nerve is here. It may be compressed. It may be compressed in the flexor carpi ulnaris muscle. Flexor carpi ulnaris muscle. Okay. And we call it the cubital tunnel syndrome. Cubital tunnel syndrome. Okay. Ulnar nerve may be compromised in the Guyon's canal or ulnar canal. Ulnar canal, same as Guyon canal. Okay. This is a canal between the hamate bone and pisiform bone. There is a group that is covered by pisiohamate ligament, or it may be damaged. We call it handlebar lesion, bar palsy, that happened in a biker who holding the handle of the bicycle for a long time, that compresses the hook of the hamate area. So that may lead to ulnar nerve palsy. Okay. So we got ulnar nerve may be damaged in multiple places. Again, we'll get claw hand. Claw hand in ulnar nerve lesion, and Wetter's tip sign in Erb-Duchenne paralysis. Claw hand is also seen in case of lower trunk damage or Klumpke's paralysis. Okay. We have one more problem may associated with the lower trunk. Okay. Maybe it may be involved in thoracic outlet syndrome. Thoracic outlet syndrome. What happened in thoracic outlet syndrome? It is due to a rib that is called cervical rib, that is connected to the C7 cervical vertebra. Okay, and that may extend to the upper surface of the first rib, and the lower trunk may be elevated there over the cervical rib, and the lower trunk of brachial plexus plus the subclavian artery both may be compromised or compressed in thoracic outlet syndrome by the cervical rib. We may have vascular problem in the upper extremity, maybe nervous problem due to lower trunk non-functioning in thoracic outlet syndrome. Okay, we may have we may have damage or lesion to the radial nerve. Radial nerve may be involved in the radial groove or spiral groove of the humerus, that is in the middle of the shaft of the humerus. Okay, radial nerve goes through the lower triangular space or the triangular interval, then between the two head of the triceps brachii muscle, along with the deep artery of the arm or arteria profunda brachii. So radial nerve may be involved in case of fracture of the shaft of the humerus. Okay, so fracture of the shaft of the humerus. Fracture of the shaft of the humerus. Okay, what will happen? Radial nerve injury, person is unable to extend the wrist joint, will develop. The person who has radial nerve injury, he will develop the wrist drop. Okay, and also we get lack of cutaneous innervation to the arm, at the back of the arm, forearm, and also lateral aspect of the dorsum of the hand. So cutaneous innervation will also be hampered due to radial nerve lesion. Okay, then median nerve lesion that is possible, especially in case of supracondylar fracture. Supracondylar fracture. Okay, supracondylar region of the humerus, there may be fracture, and the median nerve may be involved. Median nerve is an important nerve. It innervates muscles of the forearm. It innervates muscles of the thenar eminence. It is also cutaneous innervation on the lateral aspect of the palm. Okay, so we may have median nerve involvement in supracondylar fracture. Median nerve may also be compressed in case of carpal tunnel syndrome. Carpal tunnel syndrome. Carpal tunnel is a tunnel formed by the flexor retinaculum and the carpal bones. So in carpal tunnel syndrome, median nerve is involved. So the muscle innervated by the median nerve will be compromised. Cutaneous innervation also may be compromised. Okay, so some intrinsic muscles will not get the innervation, especially the lateral to lumbricus, and some of the thinner muscles like abductor pollicis brevis, opponens pollicis brevis, even the flexor pollicis brevis. Okay, so the abductor pollicis brevis, opponens pollicis, and the flexor pollicis brevis, and also cutaneous innervation will be disturbed due to carpal tunnel syndrome, due to compression of the median nerve under the flexor retinaculum. Okay, we got the median nerve lesion. Okay, so we have other nerve like suprascapular nerve palsy that may happen, especially entrapment of the nerve in the suprascapular notch of the scapula. So the supraspinatus, infraspinatus muscle will be deprived of nerve supply, so they may not function. Okay, that may happen due to suprascapular nerve entrapment in the suprascapular notch of the scapula. Okay, we have lesion to the root. Okay, root, maybe the upper root, maybe the lower root. Also lesion to the long thoracic nerve. Listen to the long thoracic nerve. Long thoracic nerve. Long thoracic nerve is coming from where? Coming from C5, C6, C7 roots of the brachial plexus. C5, C6 and C7 roots of the brachial plexus. Long thoracic nerve innervates the serratus anterior muscle, which keep the scapula connected to the back. So if this is paralyzed, the medial border of the scapula will be prominent. When the person push on the wall, if you look at the back of the person, if you will see the medial border of the scapula will be prominent coming out of the chest because of the long thoracic nerve innervating the serratus anterior muscle. Okay, so listen to the long thoracic nerve will cause paralysis of the serratus anterior muscle. Okay, we got that. So we may have different type of injury. It may be birth trauma, it may be falling from the motorcycle, it may be due to violence, or in case of excessive traction or excessive separation of the head and neck from the shoulder, we will have upper trunk lesion, excessive separation of the body wall and the upper extremity, the arm. Then they will have lower root traction will happen. The brachial plexus injury may be associated with Horner syndrome because the spinal nerve are connected to the ganglion by means of white and gray rami communicants. And if the cervical segment of the sympathetic chain is not getting the continuation of sympathetic nerve fiber from the lateral gray horn, then certainly we will have Horner syndrome. It depends on the type of injury and the extent of injury, usually lower trunk lesion associated with Horner syndrome. Okay, so we got the brachial plexus injuries. Brachial plexus injury may happen as a part of the neuralgic, we call it amyotropic neuralgia. Amyotropic neuralgia. Okay. So this is a condition. It may be genetic. So some nerve may not function properly and it may be painful condition. It may last long. In amyotropic neuralgia, it may involve any nerve. Or brachial plexus may be involved in demyelinating disease. Demyelinating diseases. So the nerve are made of axons, they are myelinated, so nerve will not function if we have demyelinating disease of the brachial plexus. Okay, so let us summarize. Brachial plexus injury is very common. Upper trunk injury is called Erb-Duchenne paralysis, muscle involvement by the upper trunk that is formed by C5, C6. Muscles involved are the deltoid muscle, the biceps brachii, the brachialis, small muscles of the shoulder joint. Okay, person cannot supinate, cannot do the lateral rotation, so hanging by the side, and we call it Erb-Duchenne paralysis. Lower trunk lesion may happen again due to the difficult delivery of the baby and person falling from a treetop. Luckily, he was able to hold a branch and could stop the falling, but his nerve root in the lower trunk, forming nerve root, will be damaged, which is called Klumpke paralysis. It is associated with claw hand. Okay, our brachial plexus not only upper trunk, lower trunk individually may be damaged in case of gunshot injury. Multiple nerve may be involved together. So any nerve may be involved. Suppose in case of suicidal attempts by slashing the wrist, the median nerve may be involved. Okay, so median nerve may be involved, may be damaged. So it depends on what type of injury, what extent of injury. So multiple nerve, multiple trunk may be damaged. So that's all about the brachial plexus injury. If you have any question, please feel free to ask me. Please share the information with your friends and please subscribe my channel. Have a nice day. Bye now. Thank you.